welcome to the deep dive. Today we're going to unpack something really vital. How to make healthcare better, even when resources are, well, incredibly tight.
Yeah, that's a big one.
We know you're looking to get a solid grasp on important topics, without getting bogged down.
Yeah.
So think of this as your direct line to understanding quality improvement in low-resource settings.
Exactly. The smart ways to boost care when things like funding, equipment, even staff are limited.
Right. So where do we pull our information from for this deep dive?
Well, we've looked at leading organizations, Joint Commission International, JCI, and the National Accreditation Board for Hospitals and Healthcare Providers. That's NABH in India.
Okay.
And also practical insights from places like Supreme Medic Consultancy, the Global View from ISQA, the International Society for Quality in Healthcare, plus several, really interesting articles and podcast discussions on this.
Got it. So our mission here
is really to pull out the core strategies, the real-world obstacles, and honestly, some genuinely inspiring stories.
The good stuff.
Yeah, how quality and safety are being elevated in some, really challenging environments. We're aiming for those practical takeaways, those moments where it just clicks for you, the listener.
Okay, let's start with the basics then. When we say low resource setting in healthcare, what does that actually, look like on the ground?
Yeah, it's kind of a mix of critical limitations hitting at once. Most obviously, you've got tight finances, right?
Right. Money.
Which affects pretty much everything. Hiring enough people, getting meds, getting equipment. Then often the buildings, the infrastructure, it's just not adequate.
Like old facilities, unreliable power maybe.
Exactly. Outdated facilities, maybe no reliable water or electricity. And a big one is often a shortage of trained healthcare professionals. That puts huge pressure on the ones who are there. And then there's the constant struggle just getting hold of essential medicines and basic supplies for daily care.
That paints a really stark picture. It sounds like just keeping things running day to day is the main battle.
It often is.
Are there other sort of underlying issues that make improving things extra difficult?
Oh, definitely. Layered on top of all that, you often find it's hard to get reliable data.
Which you need to know where the problems are.
Exactly. And to track if changes are working. Plus, you might lack effective management systems, ways to organize things efficiently.
Makes sense.
And maybe the toughest part. The healthcare workers themselves are often under just immense pressure, which, understandably, can make it hard for them to find the bandwidth to even think about quality improvement projects, no matter how important.
So with all those challenges, really fundamental ones, stacked against them, it almost makes you ask, why even prioritize quality improvement in these settings? Isn't it like trying to repaint a house while it's, on fire?
That's a powerful way to put it. But here's the thing. Quality improvement isn't some kind of luxury item for rich hospitals.
Okay.
You could actually argue it's more critical in low-resource settings. Think about it. When resources are scarce, any inefficiency, any error, any preventable complication...
It hits harder.
It hits much harder. It leads to worse outcomes for patients and puts even more strain on the few resources you do have. So focused QI efforts, even small ones, can lead to surprisingly big gains.
How so?
Well, better patient care, obviously, but also making things run more efficiently, which saves resources. Ultimately, it means better healthcare overall, making the absolute most of every single thing available.
Okay, this is where it gets really interesting for me. Given all those constraints, how do you actually start improving quality? What are some key strategies that actually work in these places?
Right. So our sources point to several key approaches that really seem to make a difference. One of the absolute most important is focusing on high-impact, low-cost interventions.
Okay, high-impact, low-cost. Like what?
Things that don't need a huge budget but give you big results, like really pushing rigorous hand hygiene programs.
Soap and water.
Basically. Soap, water, maybe some simple alcohol rub, and education. The cost is minimal, but cutting down on hospital-acquired infections, that impact is huge.
Yeah, infections are a massive problem.
Huge. Or think about basic communication skills training for staff. Doesn't cost much, but it can boost patient satisfaction, help people stick to their treatment. Again, no fancy tech needed.
Simple conversations.
Simple conversations. And just ensuring that the equipment you do have is properly sterilized regularly. That prevents complications, saves lives, saves money down the line. Basic, but critical.
Those sound really practical. Almost common sense, but maybe easily overlooked when you're overwhelmed.
Exactly. And that leads to the next point, process optimization.
Looking at how things are done.
Precisely. Instead of jumping to expensive solutions, you look at the existing workflows. How can we make them smoother?
Examples.
Maybe streamlining how patients move through the clinic to cut waiting times, or simplifying paperwork, nurses spending less time writing, more time with patients.
Documentation, always a big one.
Always. Or setting up clear step-by-step guides, standard operating procedures, SOPs for really critical tasks. That brings consistency, reduces errors. It provides that clear structure you mentioned, which is gold when things feel chaotic.
Now, data. You mentioned data is tricky. How do you use data to drive improvement if you don't have fancy electronic health records or analytics teams?
Yeah, you're right. Those big systems often aren't realistic, but QI doesn't always need big data. The key is collecting basic but meaningful information.
Like what kind of info?
Things that show you where the problems are and if your changes are helping, like maybe tracking outcomes for the most common conditions you treat, or monitoring infection rates, or even just seeing how many patients are actually taking their meds as prescribed.
Okay, so simpler metrics.
Simpler but focused. And you can use low-cost tools. Paper logbooks work, simple spreadsheets, even using basic mobile phones or SMS messages to collect some data points can be surprisingly effective. It's about starting somewhere.
It really strikes me that, getting the actual healthcare workers involved must be absolutely essential.
Oh, fundamental. You cannot have sustainable success without it. Building a strong culture of continuous improvement means involving the frontline staff actively.
The nurses, the doctors, the support staff.
Everyone, creating an environment where they feel empowered to say, hey, this part of the process is broken, or I have an idea to make this better.
Even small ideas.
Especially small ideas. And fostering a culture where mistakes are seen as learning opportunities, not something to hide or blame people for. That's crucial for driving improvement from the ground up.
And it sounds like these places probably can't do it all alone either. Are partnerships important? Collaborations.
Invaluable, often.
Yeah.
Partnerships can bring in resources, training, technical know-how that just isn't there locally.
Like working with NGOs or universities.
Exactly. NGOs, universities, international health groups. Just sharing knowledge and best practices with other clinics facing similar struggles can spark ideas for effective, low-cost solutions. And even things like telemedicine partnerships, connecting local doctors with specialists remotely, can boost care quality without needing big infrastructure changes.
Okay, so we've got strategies: low-cost focus, process tuning, basic data, culture, partnerships. But let's flip it. What are the really stubborn hurdles, the things that constantly get in the way?
Well, as we touched on, the lack of money is it's a constant pressure. It affects staffing, supplies, everything.
The fundamental constraint.
Absolutely. Then there's often the shortage of skilled staff. That doesn't just strain the current workforce. It limits your ability to train people on new things, to implement changes.
Right. And the infrastructure.
Weak infrastructure is a big one. Unreliable electricity, no clean water sometimes, limited tech. These can be huge barriers to even simple improvements.
And what about people? Just resistance to change. That happens everywhere, right?
It does. It's human nature, especially in stressful jobs. People get used to routines. They worry about more work. Sometimes there are cultural factors.
So how do you overcome that?
It takes strong leadership, someone championing the change. Clear, consistent communication about why it's needed and what the benefits are. And crucially, showing people the positive results of even small changes. That builds trust and buy-in.
That makes sense. Are there bigger picture things too, external factors?
Definitely. We can't ignore things like political instability in a region, economic crises, or major disease outbreaks. These can completely disrupt healthcare and make it incredibly hard to sustain any improvement efforts. It highlights why strategies need to be flexible and resilient.
Okay, so despite all these really significant obstacles, you mentioned inspiring stories. It sounds like QI has been successful in many LRS. Can you share some of those real-world examples? Give us those aha moments.
Absolutely. Think about maternal and child health improvements across parts of sub-Saharan Africa.
Okay.
By focusing on relatively low-cost things, like making sure skilled health workers attend births, promoting basic clean delivery practices, scaling up immunizations, there have been remarkable gains in survival rates, without needing massive hospital construction projects.
Wow.
Or look at India. The ASHA program accredited social health activists. It trains women in communities to deliver essential health services.
Right down at the village level.
Exactly. It's massively improved healthcare access in underserved rural areas. Plus, they help collect vital health data, empowering local people.
those are big system-level examples. What about specific changes within a single hospital or clinic?
Yeah, we have great examples there, too. I read about rural hospitals in Kenya where they really focused on improving basic hand hygiene and getting sterile procedures right.
The things we talked about earlier.
The very same.
Yeah.
And they saw a significant drop in healthcare-associated infections with very little money spent.
Amazing. Any other specific cases?
Oh, yeah. In Rwanda, there was a project using a PDSA Cycles Plan Dose Study Act. It's a simple quality improvement method.
Okay.
They used it to improve the availability of oxytocin, a drug needed after childbirth.
Yeah.
The result, a 60% reduction in postpartum hemorrhage. 60%. That's a huge killer of mothers.
60%. That's incredible.
Isn't it? Or in Bihar, India, the Care Companion Program. They trained family members using simple videos and flip books on how to care for newborns after discharge. Big improvements in basic care, like early breastfeeding.
Using families as part of the care team.
Exactly. And in Sierra Leone, after the Ebola crisis, they introduced the WHO Safe Surgery Checklist. Just the checklist and some basic training for the surgical teams.
I've heard of that checklist.
It's powerful. It helps cut deaths during or shortly after surgery by over 40%.
Wow. 40%. Those are staggering results from what sound like relatively straightforward changes.
They really are. It drives home the point. You don't always need the highest tech or the biggest budget to make a massive difference in patient safety.
Yeah, it seems like simple tools like those WHO checklists you mentioned, that they could be implemented with just paper and some training, right?
Absolutely. Paper forms, clear instructions, a bit of training. They're designed to be effective even when resources are very limited.
So thinking about healthcare folks or organizations wanting to implement QI in these tough settings, what are the core principles they really need to keep front of mind?
Okay, several guiding principles really stand out. First, start small and scale up.
Don't try to boil the ocean.
Exactly. Pick a few high-impact, low-cost changes. Show they work. Build confidence. Then expand gradually as you learn and build capacity.
Makes sense.
What else? Contextual adaptation is vital. What works in one place might need tweaking somewhere else. QI methods have to fit the local reality, the culture, the social factors, the specific economic constraints.
Not a one-size-fits-all approach.
Definitely not. And staff empowerment, we keep coming back to it, but it's crucial. Involve frontline staff in identifying problems and designing solutions. They know what's really happening. That leads to ownership and makes changes stick.
Right.
And finally, think data light, action heavy. Focus on collecting just enough basic relevant data to guide your next steps, to take action. Don't get paralyzed trying to build a perfect, complex data system if it's not feasible.
Data light, action heavy. I like that. It sounds like there's this real focus on practical, often low-tech solutions. Can you give us a few more concrete examples of these interventions, maybe broken down by area?
Sure. For infection control, beyond hand washing. Simple things like setting up locally made hand washing stations where needed, clear rules on using gloves properly.
Okay. Maternal and neonatal care.
Using partographs consistently to monitor labor, providing clean birth kits, just basic essential items. Promoting kangaroo mother care, skin-to-skin contact for premature babies. All low-cost, big impact.
Medication safety.
Using tall man lettering on labels to make look-alike drug names distinct. Basic checklists for dispensing meds like double checks, simple things that prevent errors.
Documentation. You mentioned simplifying.
Yeah, standardized paper forms for patient summaries or discharge instructions can make a huge difference in clear communication between staff or with patients.
Supply management. Keeping track of things.
Even basic visual systems help, like color-coded bins for different supplies, simple manual logbooks for inventory. It reduces waste, helps make sure things are there when needed.
And clinical skills. How do you boost those without expensive training programs?
Regular, short bedside teaching sessions. Putting up posters with key local treatment guidelines right where people work. Quick reminders reinforcing good practice.
So, when it comes to actually measuring if these things are working, what are some realistic ways to do that if you don't have sophisticated data tools?
Keep it simple and actionable. Use basic run charts, just plotting a key measure over time on graph paper or simple tally sheets. That gives you a visual sense of trends.
Okay, like tracking hand washing compliance.
Exactly. Or the number of infections per month. Where possible, maybe use mobile apps. Things like ComCare, DHIS2, OpenMRS are designed for these settings and can handle basic digital data capture and really focus on process indicators. Are people actually using the partograph? What percentage of the time are they following the hand hygiene protocol? Those tell you immediately if the change is being implemented.
That makes sense. You get faster feedback. It feels like building up the local skills, the local capacity for QI must also be key for making this last.
Oh, absolutely critical for sustainability. Identifying local staff who are keen and training them to be QI champions within their own teams or departments, they can then lead and sustain the efforts.
Local leaders.
Yes. And encouraging peer learning. Simple things like quick morning huddles to discuss quality issues or regular case reviews to learn from experiences, that builds a shared understanding and problem-solving ability.
And recognizing people's efforts.
Yeah.
Does that matter?
Hugely. It doesn't have to be expensive bonuses. Simple things like certificates of appreciation, maybe mentioning someone's contribution in a team meeting. Public acknowledgement goes a long way to boost morale and keep people engaged in improvement.
Okay, so finally, boiling it all down, what are the absolute strategic must-haves? The things that really need to be in place for QI to succeed in these challenging places?
All right, number one. Leadership buy-in. You really need support from leadership. It doesn't have to be everyone at the very top, but at least one influential leader who truly believes in QI and champions it. That makes a massive difference.
One key champion
can be enough to get things moving. Second, strategic partnerships. Don't try to do it all alone. Leverage external organizations, NGOs, universities, global health groups for resources, expertise, support.
Tap into outside help.
Yes. And third, establish basic feedback loops. Use those simple charts we talked about. Have regular team meetings or debriefs to look at the data, talk about what's working, what's not, and learn together. That continuous cycle of action and reflection is essential.
This has been really enlightening, a fantastic deep dive. So just to wrap it up, it sounds like QI in low-resource settings, it's not really about fancy gadgets or huge budgets at all, is it?
Not primarily, no.
It's more about being smart, strategic, focusing on those cost-effective things that give you the biggest bang for your buck, optimizing how you already work, using even simple data to guide you, building strong collaborations, and really nurturing that local culture where everyone feels responsible for making care better for patients.
That's it, exactly. It's fundamentally about shifting the mindset, moving away from thinking low resource automatically means low quality.
Yeah. And recognizing that through ingenuity, through focused effort, through local ownership, even healthcare settings facing really tough constraints can deliver care that is safer, more effective, and importantly, more respectful for patients.
That's a really powerful takeaway. You know, it makes you think. If these principles, prioritizing high-impact actions with limited resources, work so well in healthcare, could we apply that same kind of thinking to other areas facing constraints, other sectors, maybe even our own lives?
That's a really interesting thought.
Definitely something for you, the listener, to mull over. Beyond the walls of hospitals and clinics. Thanks so much for sharing all this expertise with us today.
My pleasure. It's important work to talk about.